Iron studies are helpful in clinical practice to look for two scenarios. The first and most common is going to be iron deficiency. Less common, we're going to be looking for iron overload, sickle cell anemia, thalassemia, or they've been receiving transfusions due to either of those conditions or because they have a blood cancer. That's going to place you at risk for increased iron. We're also check iron studies if we have a family history, a personal history of hereditary hemochromatosis. Most often in clinical practice, we're checking iron studies because there's concern for iron deficiency. The most accurate iron studies are going to be drawn in the morning fasting. There's three main categories of reasons why a patient might be iron deficient. So the first one is they can't absorb iron in their diet. The second one is they're chronically bleeding. Most often this is going to be GI bleeding or menstrual blood loss. And the third one is pregnancy. In pregnancy, iron will cross the placenta to allow for adequate iron stores in the fetus, and all pregnant patients should be screened for iron deficiency. The two most common reasons why somebody might not be absorbing adequate iron in their diet are, number one, they've had surgery on their bowel, or they have a chronic inflammatory GI condition like celiac disease or inflammatory bowel disease, which prevents them from absorbing iron adequately through their gut. The second one is in children. Children are at high risk for iron deficiency early in life when they may not be eating a lot of iron-rich foods, or they may be consuming high quantity of cow's milk, which is competing against iron absorption. Menstrual blood loss is the most common reason to become iron deficient through bleeding. GI bleeding is also seen pretty commonly. The other situation in which you would send iron studies is if you have a complete blood count that shows microcytosis, meaning the size of the red blood cells is small. On most assays, this is going to be an MCV of less than 82. There's really two circumstances in which you're going to have chronic microcytosis, and that's either iron deficiency or the patient is a carrier of thalassemia. So in summary,